Hello everyone, in this video we are going to see about vesicular mode. I am S. Ruth Kesia working as a tutor in Trippuram College of Nursing. Objectives: in this video we are going to learn about introduction, definition of vesicular mode, incidence and prevalence, types of vesicular mode, pathophysiology, etiology, clinical features, physical examination, investigation, complication, management, nursing management, prognosis of vesicular mole. Introduction. Vesicular mole is a gestational trophoblastic disease in which abnormal proliferation and degeneration of trophoblastic villi occur. The cells degenerate and become filled with the fluid, giving grape-sized vesicles. A hydatidiform is also known as the vesicular mole. It is a gestational trophoblastic malformation in which the chorionic villi. This chorionic villi will be present in the placental bed. What happens in hydatidiform mole? This chorionic villi will proliferate and become avascular. Definition: it is an abnormal condition of the placenta where there are partly degenerative or partly proliferative changes in the young chorionic villi. These results in the formation of cluster of small cysts of varying sizes. Because of its superficial resemblance to hydatid cyst, it is named as hydatidiform mole. So this is the definition of hydatidiform mole. Next is the incidence and prevalence. The estimated number is 1 of every 1,000 to 2,000 pregnancies. The incidence of hydatidiform mole is 0.5 to 2.5 in the Western world and 1:160 to 1:400 in India. The risk rises where the mother has previously had molar pregnancies. The incidence is high at the beginning and the end of childbearing period under 20 and over 40 years of age. Then the risk also gives to poor nutrition, protein deficiency, consanguinity marriage, and maternal blood group of A and paternal blood group of O, and genetic disposition. So these are the incidence and prevalence of hydatidiform. Types: there are two types: partial, which is incomplete molar pregnancy. There is an abnormal growth of placenta and some fetal development. In complete molar pregnancy, there is an abnormal placenta but there is no fetus. Complete hydatidiform mole have a higher rate of developing into choriocarcinoma, a malignant tumor of trophoblast cells, than do partial mole. Now let's see about these types in detail. First is partial mole. In this type, the evidence of an embryo, the fetus or amniotic sac, may be found as death occurs at 8th or 9th week. It means the embryo or the fetus will be there, okay, which has to be there, will be there, but it will be dead in a partial mode. Okay, the hyperplasia of the trophoblast is confined to single syncytotrophoblast layer and is less widespread than in complete moles. It means what we are saying, the proliferation of the chorionic villi is confined to a single layer in a partial mole. It means the chorionic villi, the widespread of the proliferation of this chorionic villi will not occur beyond the placental bed. It means it won't go to the myometrium, it won't invade into the myometrium of the uterus. And the chromosome analysis usually shows this to be triploid with 69 chromosomes, that is 3 sets of chromosome, 1 maternal and 2 paternal. The risk to the mother of developing choriocarcinoma from a partial mole is slight. Follow-up, however, is still essential. So this is about the partial mole. Next, we'll go to the complete hydatidiform mole. This type of mole contains no evidence of embryo or cord or membranes. So as I said, in partial mole, the fetus or the embryo or the amniotic sac will be present, but it will be dead. In complete hydatidiform mole, there is no evidence of embryo, cord or membranes. The death of embryo occurs prior to the development of placental circulation. The chorionic villi alter to form a clear hydropic vesicles, which hang in clusters from small pedicles. The mass occupies the entire uterine cavity and can be large enough to mimic an advanced gestation. The developing mole penetrates into the uterine wall beyond the site of implantation, Myometrium can be involved and more rarely the veins. The rupture of uterus with a massive hemorrhage is a possible outcome. Complete moles usually have 46 chromosomes of paternal origin only. Choriocarcinoma can develop from a complete mole. So this is about the types of molar pregnancy. Next we'll go to the pathophysiology. So what happens here? Choriodecidual spaces is obliterated. Okay, so choriodecidual spaces means the place where the placenta attaches to the uterus, okay, to the inner layer of the uterus, that is the endometrium. The endometrium is otherwise called decidua. So the space is called choriodecidual space. So this space becomes obliterated. It means it gets blocked. Okay, maternal blood cannot circulate here. So usually there will be interchange of nutrients, oxygens, electrolytes, all the essential items to the fetus in this space. Okay, there is no direct mixing of blood, but the essential electrolytes, oxygen and nutrients will go to the fetal blood circulation in this space only. So where the maternal blood here, because of the block, the maternal blood cannot circulate. Creamy white appearance will occur, and because there is no intervillous blood circulation, the blood will not reach the fetus, and no oxygen and nutrients reaches the fetus, and the fetus die and become absorbed. So this is what happens to the fetus. What happens in placenta? So usually there is chorionic villi. So all this chorionic villi only forms the placenta. The young chorionic villi undergoes a degeneration, undergoes some changes called partly degeneration or partly proliferation changes. So all this will lead to the chorionic villi will continue to multiply, and the uterus becomes enlarged, and also it is filled with the fluid, and there is no intervillous blood circulation. So because the chorionic villi is continued to multiply, it forms a formation of cluster of small cysts of varying degree and collectively take appearance of a bunch of grasps. Okay, bunch of grasp, that's called hydatidiform mole. So this is about the pathophysiology. Next, we'll go to the etiology. Hydatidiform results from overproduction of tissue that is supposed to develop into placenta. Highest in teenage pregnancies and women over 35 years. Faulty nutrition. So this we already seen in the incidence and prevalence. And faulty nutritions like inadequate intake of protein, animal and keratin. Disturbed maternal immune mechanism. Cytogenetic abnormality, higher ratio of paternal, history of prior hydatidiform mole. So these are the reasons for hydatidiform mole to occur in a gestation. Clinical features, symptoms, age and parity, vaginal bleeding, lower abdominal pain, constitutional symptoms like patient becomes sick without apparent reason, vomiting in pregnancy, breathlessness, thyrotoxic feature, passing of grape-like vesicles per vaginum. History of quickening is absent because there is no fetus, there is no quickening. And because the vomiting will be higher because this chorionic villi will continue to excrete HCG in the urine. Okay, so the HCG, the higher levels of this HCG will cause more vomiting and hyperemesis gravidarum in this pregnancy. Signs: patient looks more ill, paler, features of preeclampsia. When you examine the abdomen, the uterus size more than amenorrhea. Feel of the uterus is firm and elastic. Fetal parts are not felt. Absence of fetal heart sound. In vaginal examination, internal ballotment cannot be elicited. History of quickening is absent. Unilateral or bilateral enlargement of the ovary. Finding of the vesicles. All this will be felt in the vaginal examinations. Next, we'll go to the investigations. Complete blood group, blood count, ABO and RH blood grouping and typing should be done. Liver and kidney function test should be done. Thyroid function test. Level of HCG and ultrasound of pelvis should be done. X-ray and MRI and CT of chest, pelvis and brain to rule out if the mole has metastasized outside the uterus. So these are the investigations needed for the hydatidiform mole. Complications: hemorrhage and shock, sepsis, perforation of the uterus, coagulation failure, anemia from chronic blood loss, trophoblastic embolization leading to severe acute respiratory problems, that is breathlessness, and toxemia of pregnancy and development of choriocarcinoma, hypothyroidism, and heart failure. So if this mole is a complete mole, there is a high chance of this hydatidiform mole developing into a choriocarcinoma, that is cancer of this carcinoma. Treatment: some hydatidiform mole disappears spontaneously, and the next option will be dilatation and curettage. Evacuate, that is dilating the cervix and evacuating the content of the uterus with the curette, and or hysterectomy and abdominal hysterectomy, that is evacuation of the mole through incision made through the abdomen into the uterus, and blood transfusion in cases of severe anemia. Chemotherapy and radiation for more aggressive moles that have become malignant. For those women who have HCG level does not return to normal levels after evacuations. So this dilatation and curettage, when it's done for a woman, you're supposed to monitor the HCG levels of the woman in the blood. Okay, so if this is not coming down, we have to suspect for the malignancy, and we have to go for the chemotherapy and radiation. This occurs only in case of a complete mole. Partial mole, there is only a slight chances of changing this hydatidiform mole into a choriocarcinoma. Okay, and next is nursing management. Reassure the patient, give psychological support to the patient, provide good environment free from external stimuli to ensure proper rest and sleep, encourage to take nutritious diet rich in protein, vitamin A and animal fat, administer oxygen therapy to relieve breathlessness, provide sterile vaginal pads to prevent urinary tract infection, encourage to maintain personal hygiene and change the clothes daily. Administer some analgesics as prescribed by the doctor to relieve pain. Monitor HCG level after the molar pregnancy every week initially. The HCG level generally drops to normal within 8 to 12 weeks after evacuation of the mole. Once the levels are consistently normal for 3 to 4 weeks, monitoring is conducted monthly for 6 months. After, advise the patient for effective contraception and not to conceive during the period of follow-up, as the mole can recur. Educate the mother for ultrasonography for future pregnancies after getting treatment of the disease, as after first hydatidiform mole, the risk of recurrence is 1.2 to 1.4%, and after second mole, the risk increases to 20%. Prognosis. So usually the prognosis is good in hydatidiform mole if it is a partial pregnancy, and also it is complete pregnancy. The prognosis is good with the close follow-up. More than 80% of hydatidiform moles are benign. The outcome after treatment is usually excellent. Close follow-up is essential. Highly effective means of contraceptions are recommended to avoid pregnancy for at least 6 to 12 months. And in 10 to 15% of cases, hydatidiform mole may develop into invasive moles. This condition is named persistent trophoblastic disease (PTD). The mole may intrude so far into the uterine wall that hemorrhage or other complications develop. It is for this reason that a positive operative full abdominal and chest X-ray will often be requested. In 2 to 3% of cases, hydatidiform moles may develop into choriocarcinoma, which is a malignant, rapidly growing and metastatic or spreading form of cancer. In this cancer, only the ultrasound will show the snowstorm pattern appearance. Okay. Despite these factors, which normally indicate a poor prognosis, the rate of cure after treatment with chemotherapy is high. Over 90% of women with malignant, non-spreading cancer are able to survive and retain their ability to conceive and bear children. In those with metastatic or spreading cancer, remission remains at 75 to 85%, although their childbearing ability is usually lost. So this is about the hydatidiform mole. We saw about, to summarize the video, we saw the introduction about hydatidiform mole, the definition, the incidence and prevalence, etiology, the clinical features, the signs and symptoms, pathophysiology, diagnostic investigations, treatment, complications, and prognosis. So I hope you gained some knowledge on hydatidiform mole, and we'll see you in the next video. Thank you for your cooperation. Thank you.